Good afternoon, colleagues. It's my great pleasure to chair the session this afternoon. And we're all very excited to hear the presentation of Prof. Bag on AML new genetic entities. I'll just be starting off with some housekeeping. I'd like to start off with some housekeeping, but I'm trying to change the slide. There we go. Okay, so the recordings can be found on Blood SA. Please add any questions or comments to the chat box, and I will monitor the chat and forward your questions to Prof. Bag. CPD points will be available. You do need to attend for 1 hour in order to get your points, and please do provide feedback. I'd like to remind you of some upcoming local conferences. In April, it is the South African Society of Medical Oncology and Stem Cell Transplant, which will take place at the CTICC, and you are all very welcome to attend. Please have a look at the Blood SA website for further information. And then another conference in June, which is the International Donor Registry Conference, which is taking place in Cape Town, and the deadline for submission for that one is the 7th of March, and there are 10 spaces on the program for oral abstracts. And then the very popular and excellent annual Hematology Oncology Symposium, which is taking place also in Cape Town at Century City in September, and I hope to see many of you there. And I'd like to thank the management team of Deep Dive, Professor Stelfer-Berg, Din, and Melanie Davids. Thank you very much for this ongoing excellent initiative. So today, as I said, we are going to be having a talk by Prof. Adam Bag on new genetic entities in AML. And next week, there will be a talk on an approach to cytoses. And I'd just like to introduce Prof. Bag, who is a Wits graduate. He went to Wits Medical School and trained there as a specialist in hematopathology. That was back in the 80s, and he unfortunately left shortly thereafter to go to the United States, where he is now Professor of Pathology and Laboratory Medicine at the University of Pennsylvania in Philadelphia. And we have been incredibly honored to have him join us for a sabbatical here at UCT since the beginning of February. And we have learned a huge amount from him since he's been here. I'm sure you are really going to enjoy this talk. And you'll understand why for the past 15 years, he's been voted by his peers as one of Philadelphia's top doctors, the only hematopathologist in the region, which includes 5 university medical centers. And in 2012 and since then, he's been noted by the US News and World Report to be in the top 1% of doctors in the US. Quite something. Prof. Bag has lectured extensively in the USA, including at ASH and other meetings and prestigious institutions, including Harvard, Yale, Stanford, Cornell, Columbia, and the Mayo Clinic. And he has also lectured internationally for the European Association for Hematopathology, the International Academy of Pathology, and ISLH, and in over 20 countries. He has more than 240 publications, many on the molecular pathology of hematological malignancies, including recently in Blood 2022, he was one of the co-authors on the international classification, consensus classification of myeloid neoplasms and acute leukemias. So we look forward to that. I'm going to stop sharing my screen and hand over to Prof. Adam Bag to take over from there. Thank you, Adam. I think you muted, Adam.
It's a pity that I was muted, or maybe it was a good thing that I was muted, but because I was waxing lyrical about many things. But in the interest of time, I won't repeat what I was babbling about. Can you see my PowerPoint? Hello?
Yes, we can see it, Adam. It's not in presenter mode yet, but we can see it. They're in
Okay.
presenter mode now. Perfect.
Thanks, Vernon, very much. And thank you, Vernon. I was thanking Jessica profusely for the introduction that I believe my mother wrote and gave to her, because none of that is really true. And thank Jessica for hosting me. Been having a lovely time. Thank Vernon for also being so kind in hosting me and being very, very helpful in getting me settled in. Anyway, so broad topic for me to cover today is genetic testing in AML, in which I'm going to be covering some newish stuff, but also some older stuff. But, there's a lot of material to cover. So in large part, I'm going to be skimming the surface, but hopefully without drowning too much in the deep. As I'm sure all attendees are aware, AML is an extraordinarily genetically complex group of diseases. And in this pie chart from the ELN, published by Hartmut Dohn as a first author in 2017, you can see the tremendous array of different genetic subtypes of AML, both established and proposed. So I'm not going to be talking about some of the translocations that are near and dear to us and with which we are all familiar, the 1517 translocation, the two CBF leukemias I'm not going to touch upon. I'm not going to talk about KMT2A, not going to talk about BCR-ABL, not going to talk about DEC-CAN or DEC-NUP214, and not going to talk about inversion 3, and also not really talk about NPM1 mutant AML, which have been familiar to us for some time now. What I am going to focus on, however, are three newer categories of AML. Number one, those related to TP53 mutation. Number two, CPB alpha mutations. And number three, what was originally called chromosome spliceosome category are the ones that I'm going to focus upon. And I'll conclude by some future directions or, proposed future directions in the field. With regard to AML with TP53 mutations, I think we all know that TP53, the guardian of the genome, its activity is initially initiated following DNA damage. But as you can see from this cartoon, there are a number of other factors that will initiate the P53 pathway, not just DNA damage. And similarly, when it is activated, it will result in, of course, DNA repair. But once again, it has a number of other activities important in cell biology, apoptosis, cell cycle arrest, autophagy, and many others. And although we know of P53 as the sort of prototypic tumor suppressor gene with its oncogenic effect due to loss of function mutations, curiously, there are also gain of function mutations that affect its activity. It's one of the most commonly mutated genes in solid tumors, but has a variable proportion of involvement in AML. In de novo AMLs, it's seen in only roughly 5 to 10% of cases, but in the context of patients who develop AML in the setting of previous cytotoxic chemotherapy, up to 1/3 will display P53 mutations, very common together with a complex karyotype seen in 70% of such cases. And these two phenomena tend to go hand in hand. Allied to the complex karyotype is the monosomal karyotype, in which P53 mutations are enriched. Older patients with AML more likely to have P53 mutations, and erythroid leukemia, which has been dispensed with as an entity by the ICC and largely almost entirely subsumed by P53 mutant AML, is another association. The WHO, just as an aside, has retained erythroid leukemia as one of their morphologic variants, with morphologic variants of AML now no longer considered by the ICC. And as I'm sure you know, for those of you who treat such patients, they have an abysmal outcome. And this was initially recognized by ELN in 2017. As the proportion of cells or the amount of p53 mutation is present by an increased variant allelic fraction, there is a greater degree of cytogenetic complexity with an even worse prognosis. And in particular, those that have a mutant variant allelic fraction of greater than 40% have a particularly awful outcome. We also know, however, that p53 is one of the CHIP mutations. It's certainly less common than the prototypic DTA, DNA methyltransferase 3A, TET2, and ASXL1 mutations, but it does account for about 1 in 25 CHIP mutations. And importantly, it's a CHIP clone that is known to expand following exposure to cytotoxic chemotherapy. Historically, we may have thought that cytotoxic chemotherapy induces p53 mutations. We've now come to learn that these pre-exist as CHIP clones, but they expand in response to chemotherapy, and hence this is a common finding in therapy-related myeloid neoplasms. p53 CHIP clones as well as ppm1D mutations also involved in DNA repair. This is the sort of layout of the p53 gene and where mutations occur. And the majority of the mutations in the p53 gene affect the DNA binding domain. And these are missense mutations as highlighted by the red lollipops in this diagram. And typically, it's the only gene that's mutated in patients with p53 mutated AML. There's a paucity of driver co-mutations, but together with the poor outcome and cytogenetic complexity, in particular monosomal karyotype, there has been some thought over the years that this may reflect a distinct entity. What about MDS with excess blasts, as it was previously called, with p53 mutations? Well, when comparing MDS with excess blasts with TP53 mutant AML, at a number of different levels, the number of p53 mutations, the variant allelic fractions, the allelic status, the presence or absence of concurrent mutations, cytogenetic profiles, the levels of measurable residual disease in complete remission, and the outcome, which is dismal with a 12% 2-year overall survival, there really is no difference at all of these levels between TP53 mutated AML and TP53 mutated MDS with excess blasts, suggesting that perhaps it ought to be integrated or merged into one category. And this is sort of thematic in a number of different genetically defined flavors of AML in the ICC classification, in which anything in excess of 10%, rather than the historically designated 20% blasts for a number of genetic abnormalities, can be considered AML or at least MDS AML. This is a survival curve showing the overlapping curves in red and blue at the bottom of both AML with p53 mutations and MDS excess blasts with p53 mutations, both highlighting the very dismal outcome as well as the overlapping survival curves. People have looked at using p53 immunohistochemical as a surrogate for p53 mutations, because unless you're doing a single gene assay in which you can get a rapid result, most people are looking at it on next generation sequencing panels, which take a while and perhaps only become evident after one has initiated therapy. So it might be nice to know if there is or is not a p53 mutation sooner rather than later. And over the years, there have been a number of studies correlating immunohistochemistry with p53 mutations, a study from Moffitt in Florida, Stanford in California, more recently by the MD Anderson group in Houston, Texas. And this is a figure from their paper where they suggested a level of 7.2% on digital studies that could distinguish, for the most part, cases in which p53 was wild type or p53 was likely to be mutated. With this correlating quite well, not perfectly, but quite well with mutational status, 94% sensitivity and 90% specificity, with the immunohistochemical studies providing a robust readout of the mutation as well as allelic status. The IHC correlated with overall survival. There were two broad patterns that they described. On the bottom left is very bright staining, or interpreted semi-quantitatively as 3+ staining, which correlated with missense mutations, particularly enriched in the DNA binding domain, whereas on the top right figure shows no staining, which correlated with nonsense and frame shift mutations. And they proposed that if immunohistochemistry was positive 3+ or more in greater than 10% of cells, that would predict a mutation, less than 5% would predict for the absence of a mutation, with a sort of gray zone in between. And we decided to, in the last year or so, to see if this worked in our hands. And we identified 3 patterns of P53 immunohistochemistry in our AML patients. The top panel shows what wild type looks like. Again, semi-quantitatively scored as 1+, 2+, or 3+. Wild type that generally showed 1+ or 2+ staining, mild or moderate staining. By contrast, those with missense mutations, in this case accounting for 20% of nuclei 3+, correlated with the presence of a missense mutation and no staining at all. What you see on the edge on the right-hand side is just edge artifact, 0% staining seen with nonsense mutations. And we plotted out our experience over the initial 3 months of how well we did as hematopathologists, correlating immunohistochemistry with next-gen sequencing. And as you can see, as we went from month 1 to 2 to 3, we decreased our false positivity with experience that we gained from getting 70% to 92% to 100% concordance over the first 3 months of testing. And I think initially we were just over-reading 2+ staining, but as we got used to distinguishing 2+ from 3+, we became a little bit better at predicting things. All right, so a brief little interlude, and this interlude is going to be interactive. Although, as Jessica mentioned, you can put questions in the chat. For this part of the session, I encourage you to unmute and to engage. So I like to travel. I'm sure most of you do as well. And one of the things I like to do when I travel is to seek out street art. So my question for you in the audience is, do you know in which city I took this photograph of this sort of Bansky-esque type street art? For those seeking CPD points, if you get the answer correct, you'll actually double the amount of CPD points you'll get. So there is some incentive to participate. This is where I hate virtual lectures, because I can't actually pick on you in the audience. I cannot see you, but I hope you'll bear with me, or at least try and guess where this picture was taken. Anybody? Pascal?
Hong Kong. People have voted for Hong Kong. 2 for Hong Kong and 1 for Japan so far.
2 for Hong Kong, 1 for Japan. This is actually, I'll carry on in a minute. This is actually Paris. This was another very well-established Parisian graffiti artist or street artist or muralist who painted these Cheshire cats all over the city, often in locations that were hard to get to. And so you wondered how this artist managed to get high up in a building to paint the Cheshire cats. Here was one with the tip of the hat to, of course, Vermeer, as well as to Gwen Stefani over here. Okay, so having established that we're now in Paris, where was this picture taken?
That must be inside the Louvre, that's there.
Yes, excellent, inside the Louvre. So why am I showing a picture of the Louvre? Well, of course, everyone who goes to Paris has to visit the Louvre, and many, many magnificent works of art to see there. This is, of course, a Botticelli. I think it's a Botticelli. I might be embarrassing myself. I'm showing these pictures because when we went to Paris, my wife and I, we were very excited to take our daughter with us. And our daughter was additionally extremely excited to come along and to be able to sort of engage in all this culture. And she read a lot about the museums and Paris and France and history. So here she is engaging in the culture of the aforementioned Louvre Museum. Here's a picture of her really loving the art in the Pompidou Center. Here she is outside on the way to Sacré-Cœur. It was very rewarding as a parent to know that all this time and expense schlepping her over to Europe paid off. Anyway, thank you for that brief indulgence. Moving along to CBP alpha mutations or mutation in AML. This is a very interesting gene that's got a single exon with 2 transactivating domains and 1 leucine zipper domain, a basic leucine zipper domain. So it stands for cat enhancer binding protein with the CCAAT, reflecting, of course, a DNA motif that is recognized by this transcription factor, and it's very important in myeloid differentiation and maturation. In 2008, it was first initially recognized as being prognostically relevant in AML, and in which the mutation was, people then didn't talk about biallelic or monoallelic, but if you had a CPB alpha mutation in AML, you generally had a good outcome. A number of years later, in the next incantation of the WHO, it was then determined that this mutation needed to be biallelic in order to be prognostic, and biallelic in a sort of compound heterozygous manner, if that's the correct genetic description. Forgive me if it's incorrect, but 2 different mutations needed to be present, one at the 5' end of the gene, the other at the 3' end of the gene. However, subsequently, in the latest incantation, both the ICC and the WHO have changed things around yet again. If I could have the next slide, please. Oh, wait, I'm organizing the slides. Sorry. So PB alpha mutations in AML, it was shown in this study from 2021 from a US, I think, pediatric cohort, that it was the basic leucine zipper mutations that were favorable, regardless of whether the mutations were monoallelic or biallelic. A subsequent study from Japan a year later showed in an adult cohort similar findings, with the BZIP mutations being favorable, and that mutations outside of this domain were in fact not favorable. And more recently than that, there was a paper, or simultaneously a paper from Germany that similarly showed that BZIP mutations were favorable, but in particular, they needed to be in-frame BZIP mutations. And so these patients have very characteristic features. They tend to be younger patients than AML. They tend to have rather elevated white cell counts, and they tend to have very bright CD34 expression, although it's treacherous really to sort of predict the mutation from any immunophenotypic findings, although some have proposed doing so. Here is a brief, not so brief, sort of detailed schema of the gene and where the mutations occur. And you can see that there are concentrated mutations on the left and the right. The ones on the left affect the N-terminal cluster of a protein involving the transactivating domains TAD1 and 2. These are frameship mutations that result in a truncated protein. These are the ones that, by the way, and I won't be talking about it, that tend to be enriched in germline mutations. CPB alpha is interesting in that it can be mutated in the germline, and that is a syndrome that predisposes to the development of AML. By contrast, the acquired ones tend to occur in the C-terminal side. They involve the basic leucine zipper domain. They're usually insertions, deletions, and mostly in frame. And those that are in frame are the ones that are prognostically relevant, and this disrupts dimerization and DNA binding. Other mutations may coexist with CPB alpha and may have confounding effects on the prognosis. So mutations that seem to be enriched in this group of patients include GATA2, WT1, and CSF3R. And the GATA2 mutations coexisting with CPB alpha, interestingly enough, seems to be associated with either a better outcome or neutral effect. WT1 mutations tend to make the goodness of a CPB alpha not so good, whereas CSF3R mutations also nullify the favorable prognostic impact in patients with CPB alpha mutated AML. Other mutations that we know are recurrent in AML, such as NPM1, FLT3, the IDHs, and RUNX1, tend not to coexist with CPB alpha to some degree, at least as far as NPM1 is concerned. And so the same, I think, is true of the recurrent translocations, that it is a specific entity. From a laboratory diagnostic point of view, it was actually quite challenging to detect the mutations because the whole gene was difficult to sequence. It's a GC-rich gene with nucleotide repeats that sort of confound one's ability to do sequencing. But now that it's been determined, at least until the next classification tells us otherwise, that it's restricted to the BZIP region, this is much easier to sequence. It's only a 90 base pair fragment and has made laboratory testing a lot more facile. The third new group that I wanted to talk about following a discussion of P53 and CPB alpha is what we used to call AML-MRC, AML with myelodysplasia related changes, which, as you know, historically, we got into this club in one of three ways, either from a history of a myelodysplastic syndrome or mixed myeloproliferative myelodysplastic neoplasm, number one. Number two, with cytogenetic abnormalities. And number three, the most irreproducible form and not terribly specific form was to do this on the basis of morphology. And so the latter has now been dispensed with, at least in the ICC, a morphologic designation of AML-MRC. But it was Coleman Lindsay at the Brigham and Women's Hospital and Dana-Farber Institute, Cancer Institute in Boston, almost a decade ago, came out with a seminal study in which she looked at different genetic abnormalities. And at the bottom, we have the sort of classic genetic abnormalities that we know and love and are associated with AML, CPB alpha, MP1, MLL1 or KMT2A translocations, and the CBF leukemias. Whereas at the top are those are the mutations with specificity for de novo AML. At the top are genes that are recurrently more likely to be mutated in MDS than they are to be mutated in AML. However, he noted astutely that these mutations were also enriched in secondary AML, with a definition of secondary AML here being either those with a history of an antecedent MDS or those that arose in the setting of prior cytotoxic therapy. And roughly a third of these so-called de novo AMLs without a history of MDS, without a previous history of being treated with cytotoxic therapy, harbored these mutations. A number of other findings that emerged from the study was that these secondary type AMLs tended to have more than one mutation. If you compare them from left to right, blue to green to red, the secondary type AMLs had an average of 3.9 driver mutations, whereas there were fewer in the TP53 mutated AML, as we've discussed before, as well as in sort of de novo other forms of AML. There were also differences with regard to cytogenetic complexity. We already heard that in green, the P53 mutated AMLs were more likely to have complex cytogenetics, whereas in this category of AMLs with these mutations, they often had fairly simple cytogenetics with one or less cytogenetic abnormality. And finally, in blue, the secondary type AMLs tended to be older than those with P53, although the numbers were close, as well as those with de novo AML. The outcomes of these patients with secondary type AML, in other words, defined by mutations in one of the 8 genes, which I'll return to in a moment, were mutated, had a very dismal outcome in the survival curve, as you can see, overlapping in large part with P53 mutated AMLs, which we've already demonstrated to be pretty awful. So these mutations identify clinically relevant, unrecognized AMLs, in other words, AMLs with MDS mutations, in cases that otherwise would have been classified using criteria up till that stage, and in fact, up till recently, as de novo AML. So here are the genes that are mutated. There were 8 that emerged from this initial study, 4 of which, the ones listed here, are spliceosome genes, which we know in general to be enriched in MDS rather than AML, as well as these other 4 genes, BCOR, ASXL1, STAG2, and EZH2. A number of other studies confirmed these findings. This was a study published by Elie Pape-Emmanuel, who I think was still at Cambridge at the time, and perhaps collaborating with a number of other groups. Hello? Sorry. Identified a number of different subtypes of AML from a genomic perspective, again, confirming what we already knew about many subtypes of AML, but also identified this group with mutated chromatin RNA splicing genes or both. And in addition to finding mutations in most of the genes that Coleman Lindsay and his group had found, also identified RUNX1 mutations being enriched in this category. And whereas only 20% of patients in the group had a history of MDS or dysplasia, there were 80% who did not and would have been considered de novo AML. Here are the outcomes of some of the subset of the patients, those without translocations. You can see at the top CPB alpha at that stage biallelic doing well, NPM doing quite well, IDH2R172 doing well, but these chromatin spliceosome and T53 aneuploidy categories doing poorly. Finally, there was this group that in 2020 really confirmed these findings. Here are the 8 genes, 4 spliceosome genes and 4 others that were associated with de novo AML, but based upon these mutations could be reclassified as ones with MDS mutations, and they too recognized that RUNX1 was an important gene. So together with the 8 genes originally identified by the Dana-Farber and Brigham and Women's group, the subsequent studies indicated that RUNX1 should be added, and now this has been inculcated into contemporary AML classification, at least by the ICC, and in large part by WHO. All right, so we didn't do terribly well with the first interactive part of the session. So I'm going to provide you with an opportunity to redeem yourselves. I would also encourage registrars to participate because I know some of the examiners on the college exams, if they're still called college exams, and some of these questions pop up on the college exams. So I'd encourage you to pay attention or at least to volunteer an answer. So here again, we're in another city, street art. Where are we? Feel free to shout out, or if Jessica can see the chat, which I cannot.
So far I've got Amsterdam, Berlin, Copenhagen, Italy.
Oi, oi. My work is cut out for me.
Germany, yeah.
Yeah, oh my golly. This is London. This is the former sort of East End of London, the Shoreditch region of London, where there's an amazing, if you like this sort of stuff, and if you don't, I'm sorry to bore you, of street art. So this was mostly in Shoreditch, more stuff in Shoreditch, more stuff in Shoreditch, even making use of some of defunct tube cars. And of course, and I don't know what sort of inspires me to do this. This is a picture of a roof or ceiling in. Anybody, please, for extra CPD points? Jessica?
Okay, we've got, well, King's Cross, Oxygen Arena, the Gherkin Building, Millennium Dome, Oxygen Arena. Quite a few votes for the Oxygen Arena.
Okay. So I haven't been to the Oxygen Arena. Maybe it's got a roof that looks like a, this is actually the British Museum. So British Museum, we've gone from the Louvre to the British Museum. Lots of stuff to see in the British Museum, lots of controversial things going on with artifacts disappearing, not only within the museum, but being pilfered from other countries, including the Elgin marbles pilfered from the Acropolis, I believe. So once again, you know, we as parents, we were so excited to take Sophia with us to enjoy this culture. It's just so rewarding to see the enthusiasm, the excitement in a young child when they encounter this marvelous stuff. So here is Sophia really taking in the culture in the actually the Tate Modern Gallery in London. Here she is in the Victoria and Albert Museum, really, really savoring the works of art there. You know, after a while, I was very lucky in getting all these shots of her, but I eventually got caught after she went shopping in Harrods. She did enjoy the shopping, by the way. And this was the sort of disdainful look she gave me that only a parent can receive of dissatisfaction. The look I got from some locals in Camden was a lot more endearing. On the one hand, a sort of nice smile, although the hand gestures may have been less welcoming. Anyway, I digress. I'll try not to have too many digressions in this lecture. So let's just sort of focus, or rather summarize what we know about genetic testing in AML today and what needs to be done. What should you be doing in your laboratories or laboratories? And so, of course, there are standard approaches that are still important to do. Classical cytogenetics or chromosomal banding analysis, FISH and RT-PCR, in addition to mutational testing that I'll get to in a second. With regard to chromosomal banding analysis, of course, this is required for a number of reasons. In all cases today, you should not be not doing cytogenetics, and you should do it for, of course, diagnostic reasons, prognostic reasons, classification reasons, and of course, dictating therapy. FISH is primarily indicated in two scenarios, in my opinion, and I'm sure you'll agree. The first scenario is where you cannot wait for the turnaround time for the cytogenetic analysis, which takes, days to sometimes weeks, depending on your laboratory. I know our laboratory in Philadelphia takes up to 2 weeks to get us a sort of comprehensive karyotype, but you cannot wait, and you need to see if there is an abnormality, since it's going to affect upfront therapy. The other consideration is where chromosomal banding analysis has been completed, but it's unclear as to what's going on, or it's unhelpful. There are probably 3 scenarios or 3 types of genetic abnormalities today where you'd want to know sooner rather than later if it is present, because that may affect therapy. And of course, that is the CBF translocations, whether there is an MDS defining cytogenetic abnormality, and if there is a PML RARA fusion. And the reasons for that, as is well known to all of us, is the patients with CBF translocations do better when monoclonal antibodies to CD33, Mylotarg, is added to a conventional, so-called conventional chemotherapy. Patients with secondary AMLs seem to do better, particularly in the 60 to 75 years age group, with the liposomal formulation of 7+3, which works better in these patients. And of course, PML-RARA patients need to be identified rapidly to be given ATRA and arsenic. There's some newer emerging trials going on at the moment, but I don't think it's standard of care just yet. But looking at patients with NPM1 mutations, or looking at patients with KMT2A translocations, to determine if there is a benefit from treating them with menin inhibitors. With regard to the other category of FISH abnormalities, they might be done to clarify if a specific gene is involved. Of course, the karyotype can be very good in saying this looks like a 1517 or a whatever that is prognostically, therapeutically, diagnostically relevant, but it's good to do FISH to confirm. Sometimes these abnormalities can be cryptic. You may have a normal karyotype. That does not completely preclude a cryptic or submicroscopic chromosomal translocation. And then obviously, if chromosome banding analysis fails for whatever reason, biologic or technical, you would still be heavily dependent on doing FISH on those cells. What about RT-PCR? RT-PCR for fusion genes at least can be done and should be done to confirm the cytogenetic abnormality or the FISH abnormality, noting that they are not redundant, and sometimes you can have a negative FISH result but a positive RT-PCR, and on occasion you may encounter a patient who looks and smells like APL clinically and morphologically, but cytogenetics is negative, FISH is negative, and RT-PCR is positive, and there are reasons why that can happen. So important to do things in a redundant fashion if it's going to affect therapy and prognosis. But of course, you also want to do RT-PCR to determine where these specific breakpoints are in genes, which FISH analysis is not going to tell you. And the reason for doing that is to determine if you have an appropriate measurable residual disease assay to track the patients following therapy. With regard to sequencing, there are now 12 gene mutations that are involved in the classification of AML. We know about these 3, NPM1 I haven't spoken about, but of course familiar to all, as well as TP53 and CPB alpha, important, as well as the 9 genes that identify AMLs that are secondary or that have emerged from a myelodysplastic syndrome. There are also 3 mutations that are currently druggable, of course, that don't affect classification: IDH1, IDH2, and FLT3. So these genes, now a total of 15 genes, are best assessed in a multi-gene assay, which is what next-gen sequencing is able to do. However, next-gen sequencing still has a fairly long turnaround time, and you need an answer that's going to sort of dictate upfront therapy, and you cannot wait for next-gen sequencing. So therefore, there are rapid and more rapid single-gene assays based upon ASO, PCR, or capillary electrophoresis that can determine if a gene is mutated more rapidly. Some of these have immunohistochemical surrogates. I didn't talk about NPM1 mutational testing, which can be useful to determine both whether the protein is mutated, but also if there's a subcellular translocation at a cellular level of NPM1 from the nucleus to the cytoplasm. And I already discussed TP53 immunohistochemistry as a surrogate for P53 mutations, with these results available within 24 hours typically, and so much more rapidly than mutational studies. What does one do now with this abundance of genetic information in AML? Where does one begin? Well, there is a hierarchy that emanated from the ICC and has now been inculcated into ELN that was published a year or so ago. So there are at least seven recurrent translocations and eversions that we all know that are listed here. APL's not in this, but of course it's also part of the equation. And there are a number of rare recurrent translocations, and there are a multitude of those. But if you've got one of those translocations, or either a mutation in NPM1 or a BZIP mutated CPB alpha, you have, and this is the sort of entry point, an AML, the recurrent genetic abnormalities, with the subtypes as dictated by the specific findings. If none of those is present, the next step in this hierarchy or algorithm is to look for mutated TP53. And if you have mutated TP53 and a VAF of greater than 10%, which is different from the requirements for diagnosing a TP53 mutated MDS, that's another story. You will now diagnose AML with mutated TP53. If that is negative, you are then authorized to proceed to look for one of the 9 mutations that we've discussed that will diagnose myelodysplasia-related gene mutations. If none of those is evident, the sort of fourth level of the algorithm to classify AML would to look for an abundance now of cytogenetic abnormalities that can be used to define AML with myelodysplasia-related, not gene mutations, but cytogenetic abnormalities. As you're aware, there is an overabundance of technologies we can use. We have karyotyping, we have FISH, we have arrays, array CGH, SNP arrays, gene expression arrays, most of which, with regard to arrays, are not used diagnostically in the workup of AML. But we have PCR that can be qualitative, can be quantitative, can be DNA-based or RNA-based. Optical genome mapping is an emerging new technology that may supplement or perhaps even replace some of the other technologies that we are familiar with. Multiplex ligation-dependent probe amplification is used in some laboratories. Of course, high-throughput sequencing, next-generation sequencing, massively parallel sequencing becoming hugely important in the clinical realm, using targeted panels directed at RNA and or DNA. In the research setting, whole genome sequencing, whole exome sequencing, whole transcriptomic sequencing or mate pair sequencing is used, but with the potential for some of these being offered clinically in the not too distant future. And of course, there is also Sanger sequencing. So might whole genome sequencing be an alternative to cytogenetics? This study published in the New England Journal of Medicine a couple of years ago hinted at this tantalizing possibility, with whole genome sequencing detecting 100% of translocations that were picked up and chromosomal numeric abnormalities that were picked up by karyotyping or FISH. And in addition, it picked up 25% of translocations and copy number abnormalities that were missed by karyotype and FISH. And in 15% of cases, this refined the risk category. So not only technically perhaps better, but also clinically and therapeutically relevant. The downside, of course, of whole genome sequencing is that it missed a number of single nucleotide variants, 8% of indels, and this affected 13% of the ELN risk at that time. And of course, the reason for that is what you gain in the breadth or length of whole genome sequencing as opposed to targeted panels, you lose in depth. And certainly for next-gen sequencing, you want at least 250 or 500, but often a greater degree of coverage, whereas whole genome sequencing typically only gets you about a 50x or to 60x depth read. This is a figure from that publication with Eric Dankavich as the first author, who proposed that going from tumor sample to DNA prep to library preparation to sequencing, bioinformatics, and a genomic report, a turnaround time of only 5 days, which was pretty spectacular. But as I pointed out, if the sequencing coverage is so low, with a depth of only 50 or 60x, the limit of detection is going to be compromised. And so this is an assay that will miss subclonal mutations, certainly has no role as currently performed for detecting measurable residual disease. So there certainly are some barriers that may be logistical, may be technical, and certainly financial for introducing whole genome sequencing as an alternative to cytogenetics. But as a group of famous hematopathologists with whom you are no doubt familiar suggested some years ago, ultimately, I think these assays are going to become easier, better, faster, and ultimately cheaper. So these assays may be used in the clinical laboratory in the not too distant future. But wait, if you call in the next 5 minutes, I will share with you a few other things. So that's not all. I think time's still okay. I've got another 12 minutes or so of babbling on. So here I go. I'm going to talk about some newer stuff that may be of value in the future. I don't know. I'm not convinced that all of these are going to be of value in the clinical realm. Some of them are being used in the research realm. But single cell analysis may supersede some of the genomic studies we do, because the downside of the genomic studies, of course, is that we're looking at bulk populations. And this limits our ability to identify rare clones and subclones and really unravel the multiple mutations that may exist in different cell populations and the sort of genetic hierarchy that certainly does exist in AML and many other neoplasms that we know to be enormously heterogeneous. And this clonal diversity has been inferred computationally in bulk analyses, but is, from a clinical and biologic point of view, but more so clinical, it's central to resistance to therapy, relapses and recurrences, and poor outcomes. And single cell analysis is the capacity to allow us to look simultaneously in single cells at the DNA level, the RNA level, the protein level, to unravel some of this complexity. I have no experience with this. I stole this from this manuscript that I've cited over here. But this technology allows you to separate single cells and interrogate them at the DNA level, the RNA level, the genomic level, epigenomic level, and the proteomic level, protein. So you can use the proteomic features to determine the lineage of the cells. You can use DNA to establish clonality trees, and you can use transcriptomal analysis to look at profiles and construct regulatory networks. So you're familiar with these sort of fish plots where we have multiple mutations in a specific sample, as illustrated here, with the DNA methyltransferase 3A being dominant, and the other mutation profiles sort of inferred, and their contribution inferred from variant allelic fractions. But with whole genome analysis, by first looking at the lineage of the cells, you can determine if you're interested in which cells are in cycle, and then look at the various clones and subclones, which cells and what proportion of cells have DNA methyltransferase 3A mutations, which have NPM1 mutations, and which ones have GATA2 mutations. Artificial intelligence and machine learning and all its ramifications is a component of just about any conversation nowadays. And this is true too in what might be installed for us in the future in classification of AML, with this particular study from 2 years ago, identifying 4 genomic clusters with very different outcomes, as illustrated here. And these were unique genomic classes that extended beyond what we currently knew about genomic stratification of AML, and it extended beyond the sort of primary mutations in AML, as well as those seen in secondary AML, illustrated in these 2 circles. And so outcomes very different based upon machine learning to stratify the subtypes of AML. Proteogenomics was used in this particular study to identify a mitochondrial subtype of AML that was enriched in mitochondrial proteins. This was not discernible by genomic studies, and these patients, as illustrated on this Kaplan-Meier curve, had a poor outcome. And of course, you know, there are agents that are being used currently to target BCL2 in the therapy of AML, but perhaps these patients would benefit even more if given venetoclax and other BCL2 inhibitors sooner rather than later. Nanopore mRNA sequencing is another technology that allows one to perform long-read sequencing of DNA, and this has been used to successfully classify genomic subtypes in virtually 100% of cases. And one of its key attributes is that it's all relative low cost, and decreasing the cost of whole genome analysis by 1 order of magnitude. So whole genome analysis is purported to cost about $1,500 US, whereas this could cost as little as $150 if that estimate is correct. And this has potential for use in low and middle income settings. So in summary, we're getting close to the end. In summary, we have spoken about AML with P53 mutations. These have been known universally to have a poor prognosis. They're associated with a complex karyotype. This has now been merged into a category of AML/MDS with mutated P53, and is an entity recognized by both WHO and ICC. AML with CEPB alpha mutations known to be prognostically relevant, but now refined to show that all you really need is a monoallelic mutation, which is as good as the biallelic mutation, as long as you've got a single, one of them is an in-frame B zip mutation. AML with MDS mutations that encompass 9 genes, 4 of which are spliceosome genes and 5 others, is now a new category of AML with myelodysplasia-related gene mutations. With that, I would like to thank you very much for your attention. Obviously, Sophia, having encountered this abundance of culture, was overwhelmed and had to take a short nap. I did get permission, post facto permission, to use this photograph of her having collapsed in Hyde Park after enjoying all those museums. And I will stop there and be happy to take questions.
Thank you so much, Adam, for this absolutely brilliant overview and presentation. We do have some questions and comments in the chat, and I'm wondering if Garrick Lorden could please unmute yourself and go ahead with some questions for Prof. Bag, please. Are you there, Garrick, or shall I read your questions? I think you might be muted, so I'm...
Hi, Prof. Sorry, I just wanted to know, just the one question I posed was the role of next generation sequencing in MRD monitoring, and if you routinely use this or have used it. I think Dr. Malherbe did say that in the chat that the sensitivity may not be as sensitive as we thought.
Yeah, well, it depends. So there's next generation sequencing and there's next generation sequencing. I think the panels that are currently used by most laboratories have a sort of a sensitivity around 2 to 5%, which is clearly nowhere near sufficiently sensitive for measurable residual disease testing. However, so they're not sufficiently sensitive. That doesn't mean we don't use them. We have used them, but I wouldn't rely on them. I mean, I think a positive result is meaningful in that there obviously is disease, but a negative result is less helpful because of the relative insensitivity of standard NGS panels. However, there are additional technologies that are being adopted using unique molecular identifiers, UMIs, or barcoding, or dual strand sequencing, and a number of other strategies where you can increase the sensitivity by a number of orders of magnitude, getting down to 10 to the minus 4, 10 to the minus 5, which is the same degree of, obviously, of sensitivity that we have with single gene assays by quantitative PCR or digital droplet PCR or flow cytometric based assays. So I think in the future, there may be a role for NGS as sensitive as the other current technologies, and also giving you a sort of profile of, you know, more than one gene at one time. Does that answer your question?
Yes, thank you so much.
Thanks.
The other part of the question, Adam, was what is your method of choice for assessing MRD in AML?
Yeah, I don't have a method of choice. And in fact, you know, although sort of people think I'm come from this big palace across the ocean that can do everything, we don't do this in-house. So we send things out to a laboratory that does many of these tests for many other labs across the country. So there are not many laboratories or academic laboratories that are doing it. There are a couple, maybe a handful. We are not doing it. So we send it to a lab, and it's sort of, and these tests are not ordered by us as hematopathologists, although we have the capacity to order whatever additional test we would like. These are ordered by treating clinicians, and both flow cytometry and mutational testing or fusion analysis is done. So, you know, if a patient's got an A21 or an inversion 16, there are RT-PCR assays and emerging digital droplet assays to monitor for disease. But we also send out for AML flow cytometry, measurable residual disease. I think there are data to show, and I'm not sure if this is in AML or ALL. I'm someone more informed can comment, but obviously if you are negative for both flow and a genetic test, you're going to do really well. If you're positive for both, you're not going to do well. And if you're positive for one, but not the other, it's in between. So there is some sense, I think, if you're able to do it, to do both tests, at least from one study with which I have some memory.
Thank you very much. There's also a question from Pascal Willem. Would you like to pose your question?
Yes, Lisa, I can hear Pascal's gorgeous accent.
Thank you, Adam, and thank you for really a very comprehensive and clear talk. It's refreshing to see back cytogenetic onto the list of tests. But regarding cytogenetic and regarding whole genome sequencing, which is terribly expensive and requires a lot of computer space, what about optical mapping? I mean, it's quite good in terms of, especially in hematology, to replace karyotyping, especially when there's a lack of skills.
Yeah, so I mean, any sort of mention about optical genome mapping on my part is without any experience whatsoever. And I'm, you know, only familiar with it from what's been published in the literature and perhaps a few conversations with the people at MD Anderson Cancer Center who seem very enamored of its ability to do a lot of good stuff. So I think that may be poised to sort of be a genetic test and a reasonably economic genetic test in the future. But I have no personal experience to share with you, unfortunately.
Okay, thank you.
Thank you.
I just have a question from my side as well, Adam. I was interested in the immunohistochemical stains for nucleophosmin and TP53, which clearly, you know, we could be, you know, widely used in resource restricted settings. What is your experience of those? Are you using them? Is that just part of a study or research project, or are you do you actually employ those stands on a routine basis in your new patients while you await results?
Yeah. So yeah, so we are doing TP53 staining routinely on all so-called high-grade myeloid neoplasms, any myeloid neoplasm with 10% or more blasts, and using TP53 immunohistochemistry to predict, and we've been fairly successful to predict whether there is a mutation or not, because our treating clinicians, you know, and as you know that those patients are not going to do well with standard chemotherapy. And so to consider alternative forms of therapy in patients with TP53 mutations that are predicted by immunohistochemistry. And when I say predict, we will always have next-gen sequencing a few weeks later to compare. And the bar graphs I shared with you were only from the first 3 months. It may have remained consistent, I don't know, but seem to be doing pretty well. But what were the options for treating P53 AML? I don't think there are any good ones. I believe the studies with anti-CD47 monoclonal antibodies have not been successful, but there are a number of other agents that might be used. With regard to, and so we did that as a form of a sort of study, but have then sort of segued that into a diagnostic test. By contrast, the NPM1 mutational testing, we do not have established in our laboratory. It's on our wish list. Our immunohistochemistry laboratory that does these tests fortunately already had a P53 assay up and running for solid tumors, so it was easy for them to set that up with a few tweaks, I think, to work on decalcified core biopsies. However, the immunohistochemical lab in our institution serves all of pathology. So we have to compete with the solid tumor people and others to get our things on the list. So that's a sort of excuse for why we haven't established NPM1 immunohistochemistry. But from, again, published literature and from speaking with colleagues who use it, it does seem to be fairly useful. And up till now, there hasn't really been an urgent need for knowing if the NPM1 is mutated or not, although that may change depending on the trials with menin inhibitors.
Thank you very much. If anybody wants to ask questions, please just unmute. Otherwise, I will read your questions from the chat. Jasmine, Ramia.
Good afternoon, everyone. Hi, Prof. Thank you for that brilliant talk. I just wanted to know if the myeloid NGS actually mentions the in-frame BZIP mutations. I know it's a novel thing and it's prognostic. Thank you very much.
Sorry, I missed the question.
The question
I just wanted to know. Sorry. I just wanted to know whether the myeloid NGS actually reports the in-frame BZIP mutations in KEPA.
I don't know what the last word that you used, KEPA?
In the CEBPA mutations.
Oh, I see.
So,
Okay. I thought
yeah.
you're talking about the fish that you can sometimes have with eggs on a Sunday morning. Kipper, no, sorry. No, it's actually, we've had those very discussions in our group. And so, yes, we have adopted a system whereby it'll not only tell you what the mutation is, we, with our genetics group, will say specifically if it's an in-frame mutation. So I think you ask a very important question. Just saying that there's a BZIP mutation, just saying there's a mutation in that part of the gene is not sufficient. Your laboratory, or whichever laboratory is doing this for you, needs to say whether it's in-frame. Absolutely, great question. And we are doing that. I don't know if everybody's doing that, but I think laboratories who report out NGS ought to be doing that. Shouldn't have to, there's just so much stuff to dissect in an NGS report to try and determine if it's in frame or not. Shouldn't be our job, but if you're not sure, I think you can ask the lab that does it to explain it or make sure they do in future.
Thank you very much. We also have another question from Pascal, and then Jonathan Oxley here from UCT has a question.
Just a very quick one. Adam, do you see a lot of leaf Romani or germline mutation with your TP53 positive AML?
I don't know the answer. So are we seeing leaf Romanis? Is that your question? I don't know. I don't think so.
It doesn't look like it, but I was just curious about this because it doesn't seem to be.
Yeah, I don't think so. I mean, I think, the usual leaf Romani cancers are solid tumors, right? I don't know too much about that. And less commonly, hematologic malignancies. I'm not aware of any patient that I've encountered that turned out to have a germline P53 mutation, leaf Romani syndrome. Of course, you could expand your question, or I could expand my answer about when you see a mutation on a somatic panel, which ours is, do you start thinking of the potential of a germline mutation? And that's another whole broad topic of discussion. And and I'm happy to talk about it, but I believe that there's slated to be a talk in a few weeks or a few months' time in this deep dive on that very topic. So I don't want to preempt any discussion about that. But certainly there are certain situations in which you see a mutation in an AML or an MDS or whatever and start thinking, I wonder if this could be germline. And there are pointers to that, but there are also, obviously, as you know, a lot of caveats about implying a germline mutation on an NGS panel, unless, of course, you get to test the patient in remission. But of course, ideally, you want to test non-hematopoietic tissue, ideally cultured skin fibroblasts.
No, thank you. We did see actually some GATA2 germline mutation, and we could identify it because it remained at a variant allele frequency of 50% after the other aberration recessed post-therapy.
Yeah, exactly. So that's great if you can do that. People try and guess at the time of diagnosis, and I think that's sort of treacherous to do that. And there's no need to do that. But of course, you need to know that, especially for genetic counseling, and obviously selection of a donor, a related donor might be an issue. Important point. Thank you.
I think we've got time for one more question. I've got lots of positive feedback in the chat as well, Adam. People thanking you for a brilliant talk and being very inspired. Jonathan, would you like to go ahead?
Can you transcribe all those positive comments to tickle my ego? There must be a way to save them. No, thanks. I really do appreciate the feedback, seriously.
Prof, thank you so much for that great talk. I wanted to ask you with regards to the use of immunohistochemistry for TP53, and you said the value is that it helps guide the clinician to using alternative therapies where standard 3+7 may not be of benefit. If you can get an early diagnosis using this technique. Is there a role, or can it be used, FISH for deletion 17p as a surrogate marker for TP53 abnormalities? That would be quite rapid turnaround, especially in contexts where the immunohistochemistry is not available for TP53.
I think it's important. It's a good question, an important question, Jonathan. Thank you. But important not to conflate P53 deletion with P53 mutation. So it's only the mutation that defines this disease. If you've got the mutation in with a VAF of greater than 10%, you'll get into this club. You don't need to have the deletion. And so they're separate things, it seems, biologically, the mutation and sort of monoallelic loss of function. Of course, the story is quite different when we're talking about P53 mutated MDS, as I think we talked about a few weeks ago, in which the criteria for getting into that club, less than 10% plus, patients with sort of low-grade MDS, it needs to be more than 50%, or it needs to be a complex karyotype, or you need to have a deletion of P53. But the point being, and again, it's an important question, and I'm maybe not answering it perfectly, but the sort of entity is defined by the mutation, not by the deletion. We do test for the deletion as well in patients, particularly those in the 60 to 75 age group, because that may identify not so much a P53 mutated AML, but perhaps a secondary AML that may benefit from liposomal Ara-C and daunorubicin.
Thank you, Prof. That's very helpful.
Okay, so I think it remains just to thank you again, Adam, for an absolutely brilliant overview and talk. We all really enjoyed it and learned a lot. And we look forward to your next presentation on this platform. And so grateful for the, for coming back to South Africa and giving back to us after all these years. Prof. Berg's been away for 35 years, so it's really fantastic to have you back, and for many of us that don't go or can't go to these international conferences, just a fantastic opportunity. So thank you very, very much.
And thank you to you again for the opportunity, the hosting, the generosity, the hospitality, and all that kind of stuff. Really love it. Thank you.
Goodbye, everybody. All the best. See you next time.
Bye.